Thank you, Susie. So that was actually very comprehensive, and it's actually covered a lot of what I was going to present as well. But what I do want to focus on is just showing you lots of pictures of normal versus abnormal. And you'll find that a lot of miscellaneous things can present randomly at levels of the neck. So I'm just going to show you lots of pictures and go through different pathologies. And then you've got a quiz by Michael that will, again, reinforce this. So next slide. So you've been through this so many times this morning and done demonstrations, but same principle. I like my neck hyperextended. It doesn't really matter whether the patient's lying flat or at an angle. For lymph nodes, they tend to be more superficial than thyroid. So actually, I might go up to the highest frequency, 15 megahertz. And this is especially useful for looking at things like superficial level 5 lymph nodes under the skin surface. You'll just find that you've got a very high resolution and assess the architecture very clearly. And then just take measurements in all 3 dimensions, as for a thyroid nodule. Thank you. As Susie has covered, the stations that we assess on ultrasound are levels 1 to 6, and just be very consistent with your description of which site it is at, the levels. So you can make serial comparison to previous scans and also follow-up scans done after the current scan. In terms of assessing level 7, you can sometimes get a good view, but it can be quite limited due to acoustic shading by the manubrium. So in terms of describing that, I would describe if I saw anything obviously abnormal there, but I think it would be quite hard to do an FNA, as it would be very hard to get a good window at this region. So in terms of the architecture, the key things we describe on ultrasound are the cortex. We want to see a uniform hyperechoic cortex, which I'll show you an example of. And then the distinct hilum is a key normal feature that we also want to see, which represents the inner medulla. I often say to my radiology trainees that a normal lymph node looks a bit like a normal kidney in the neck, because it's just got that classic architecture. So on to the next slide. This is just, Susie has covered this, but just very, this is what you want your report of a lymph node to include. The site, which level of the neck it's at, the size. We use 10 millimeter short axis as our normal cutoff. Although for level 2A, these nodes can often be a bit prominent, and sometimes I do allow up to 12 millimeters if the morphology is absolutely normal. However, I would mention this in my report if this is the case, so that the clinicians are aware. Obviously, morphology and architecture in terms of hilum and cortex. The shape, we want to see a nice oval kind of kidney bean sign rather than the rounded worrying sign. And then any ancillary features, you might get things like edema and heterogeneous soft tissue appearances in nodes with extracapsular spread. So all of these are key features to mention in the report. And that just summarises that. And I think in radiology, we would say that the morphology is the most important factor rather than the size. I've seen 3 millimeter lymph nodes, but if they're rounded or don't demonstrate a distinct hilum, I would still be concerned and would attempt FNA of these lymph nodes. And obviously comparison with serial examinations and baselines are key when measuring the size of lymph nodes. So it's always important to make reference to this in your report. So this is just an example of a really nice normal lymph node. And this is a palpable lymph node at the parotid tail in this case. So as you can see, it's got a really nice oval shape. The cortex is very uniform in echogenicity, in that it's a low echo cortex, a uniform thickness. It's got that central distinct echogenic stripe, the hilum, so that's very clear. And if you were to put the vascular Doppler flow on, you'd want to see an organised hylovascularity going through that hilum rather than a disorganised one that might just go around the lymph node or inside, which I'll show you an example of. And normally 10 millimeters is our cutoff, as I've mentioned. Thank you. So now for pathological lymph nodes, it's basically an absence of all of those features that I've described. So these lymph nodes tend to be rounded in outline as opposed to oval. So here is quite a good example of that on the top right. And you can see even if they're oval, they're not quite the perfect oval shape. So anything with a sort of indistinct outline or a rounded appearance is something that we worry about. This often goes hand in hand with a cortex that isn't quite uniform and hyperechoic, as I showed you in the previous slide. You can see the cortex in all of these. Actually, could you dim the light? Oh, sorry, yeah, thanks. You might just be able to see the images more. I just realised that. Thank you. So, for example, all of these have a heterogeneous cortex. You can see it's not quite hyperechoic. But in this one especially, you can see that there's actual cystic change within the cortex. And this points towards things like metastatic squamous cell carcinoma. Although, as I'm going to show you, anything can look like anything in a lymph node. The main thing is to detect that this is an abnormal lymph node and target it for FNA. So my first example is an example of metastatic papillary thyroid carcinoma. These presented as obvious palpable lumps in the patient neck. Unfortunately, she waited a few months before it presented, and these were present throughout levels 2 to 4. And sure enough, I found the culprit, a U5 nodule in the thyroid gland. You can see these are just really obviously abnormal. They just kind of look solid inside, quite heterogeneous. And if the cortex was more hyperechoic, I might convince you that you can see like little echogenic foci within it, like bits of microcalcification. Although what I would describe in this report, that there are very punctate echogenic foci raising suspicion for microcalcification. I think it's quite difficult to be sure in this case. On the far right, you can see that there's a very disorganized vascularity going everywhere, really, apart from the hilum. So this is just a very obvious abnormal lymph node that I would target for FNA. And in this case, I did both the thyroid nodule and lymph node at the same time. So this is a case kindly contributed by Fiona as well, which is absolutely terrifying in my opinion, because this to me just looks like a simple cyst in the neck. It's got a very thin, smooth wall, completely anechoic, no vascularity at all within the lesion. So this is something that I would have described as a purely cystic lesion. I think the key thing is its location. I believe this is at level 4, if that was right. Also, the patient was clinically well. Is that correct? Yeah. 3 years old. Yeah, absolutely terrifying. So the only thing that she presented with was this at the start. So this is actually a cystic metastatic papillary thyroid carcinoma. So just be aware that, just be worried of any cyst in the neck, no matter what the age. An abnormal lymph node is always your first concern. So always target it for FNA to exclude malignant cells. So this is one of my, I see this quite a lot at North Manchester actually, but in this case I had a 15-year-old Caucasian female, generally quite well in herself, and she's got this irregularly thick-walled lesion in level 2 of the neck. And I think no one even considered that this could be a lymph node because of her age, 15 years old. They thought this is a complex inflamed branchial cleft cyst, had the relevant cross-sectional imaging, CT and MR, that showed that this looked like an inflammatory cyst. So came to my list, I did an FNA, but instead of the thin, creamy fluid that you often get with branchial cleft cysts, like the cholesterol crystals, I got this very purulent exudative material, sent it off for cultures, and sure enough, it's TB. So yeah, TB lymphadenitis is always something to be aware of in terms of thick-walled cystic lesions within the neck as well. So I think the learning point from these is any cyst in the neck, always stick a needle in to exclude an abnormal lymph node. So on to my next case. So as Fiona has mentioned actually in her presentations, these are the classic features that I tend to see in the lymphoma cases that come to the head and neck list. For example, on the bottom right, you can see that these lymph nodes have a kind of like pseudocystic appearance in that they appear very hyperechoic, they're rounded, and in multiplicity, this does point towards something like lymphoma, although I have seen isolated lymph nodes presenting as lymphoma as well. As you can see, again, rounded, no distinct hilum, and just generally the cortex looks a bit heterogeneous in some cases. Obviously, clinical history is key, and if there are any B symptoms and the lymph node is large enough, core biopsy is the thing you want to attempt first, as this is essential to get a histological diagnosis, do all the immune markers and things like that for the hematology team. So yeah, this is just a classic example of high-grade lymphoma. This is something that we see, again, quite a lot at North Manchester. So this is an example of granulomatous lymphadenitis. You can see that this lymph node in particular has a very ovoid outline. And I find that with granulomatous lymphadenitis, they can often still preserve their ovoid outline quite clearly. However, you can see the cortex is heterogeneous. You can see that there's this punctate echogenic foci within it, probably secretly of the calcification that you get in granulomatous lymphadenitis. So whenever I see lymph nodes that look like this, I kind of send it for the holy trinity of investigations, as I call it. So I'll send this off for normal cytology to exclude malignancy. I'll send it off for TB cultures, microbiology, but I'll also send it off for flow cytometry to exclude anything lymphoproliferative that's just presenting in a weird way, as you can get a lot of lymphoproliferative disorders that just look a bit odd like this with a slightly heterogeneous cortex. So now I've just got a few examples where I've done the scan and patients well in themselves and clinically suspected to be a reactive lymph node, but something's just not quite right. And you can see in both these cases, the cortex just looks very heterogeneous. And although the hilum is preserved and the ovoid outline, well, that's the case on the left side. On the right side, that you can't actually see the hilum. Something's not felt quite right, and I've done an FNA, and actually it's come back as a reactive lymph node. However, always trust your clinical suspicion, because both these patients presented again a few months later. So for the case of the left-hand right level 2 lymph node, this was. So the patient just had this isolated lymph node, came back for a repeat surveillance scan. I just went ahead and did a core biopsy, and this came back as a low-grade lymphoma, despite being a reactive lymph node a few months prior. So just always correlate with the clinical history, and luckily the clinicians were on the ball with this one. And same for this node on the right side. Actually, I had a high level of suspicion, as the patient did have a background of treated oropharyngeal malignancy. And although this came back as reactive, it was discussed at MDT, and they repeated it a few months later. Unfortunately, by this time, the nodes had progressed throughout the neck, and this came back as a recurrence of an SCC. So what I'd say is just always go by your clinical judgment, and we will act on it as well as radiologists. Sorry, I think this is not the, is there an updated presentation that, unless, are there more pictures in this? Because I've got some amazing pictures that I've added last minute. Sorry about that. Yeah. So they're both, yeah, I think it will be this one, yeah, from this morning, yeah. Yes, perfect, yeah. Great, so if you could just, in fact, I'll just come over to that. Thanks. So we've done that. So. Yes. Thank you, yeah. That's perfect. This next case, kindly contributed by Susie. So this is a patient that didn't have a known malignancy, being upper aerodigestive tract or skin. However, you can see that this is an obvious abnormal lymph node. You can see there's no hilum within it. It's quite rounded in outline, and this again confirmed to be SCC. So this just shows how morphology of a lymph node is the most important thing in assessment, even if there is no known clinical history. So everything just kind of complements each other. Thank you. So this is an example, a really good example actually, of a lymph node. And as you can see, you can't see the margins of this lymph node very clearly at all. It's kind of blended in to the adjacent subcutaneous tissue. It's got a very irregular outline. The cortex is completely heterogeneous. You can't even appreciate a hilum. And this is a case of a lymph node with extracapsular spread. So you can actually get a lot of information on ultrasound rather than cross-sectional imaging alone. Yeah, I've shown this case, thank you. And I've shown this case as well, thanks. So again, an amazing case from Susie, but this is an example. I believe this was a young patient. And you can see that this just does not look normal at all. You've got this ovoid heterogeneous lesion. The cortex it's just very weird looking. It's heterogeneous. It's got this multiple echogenic foci within it. And I believe this has come back as Castleman's disease. So, yeah. Yeah, so I've actually not seen this at all. Like, so amazing case too. Yeah, and I believe there was something like germinal matrix conversion or something like that, which could explain its strange appearances. But so that's why I actually put in my reports, even if I do think something is lymphoma, I'll just group it under lymphoproliferative, and that just covers like a range of conditions. Thank you. So next slide. Yeah, and I've done this one. Thank you. And this was another case contributed by Susie. I thought this one looked like granulomatous lymphadenitis on the left-hand side, in that it was hyperechoic and had some echogenic foci within it. But as I mentioned, this is something that I'd send for the trio of all investigations. Can't exclude malignancy, can't exclude other things, lymphoproliferative. So see a lymph node like that and just send it for those investigations. At the bottom right, oh yeah, so that was just a slightly heterogeneous lymph node as well. And again, this is something that I'd send for all three because it just looks very unusual. Thank you. So yeah, I showed these cases, thanks. And this is just an example of some lymph nodes. Again, very sub-centimetre, but they do look a bit heterogeneous. In this case, if the patient was clinically well, what I might do, because I can see the hilum clearly and it's got an ovoid outline, I might do a follow-up scan in 3 months' time, and then that way I'm playing it safe. And if they do increase in size, we can do an FNA when the time comes as well. But this is something that I wouldn't be quite sure about, but I would definitely follow it up. Thank you. And then, this is a really interesting case as well. So I believe this patient had a background of NF1, and they've got this heterogeneous lesion at level 1B, which looked to be close to the submandibular gland. And this came back as an adenocarcinoma. So just to be aware, you know, anything could be anything really, all levels throughout the neck. So not everything is a lymph node, essentially. Thank you. So in terms of reporting these cases, as I mentioned, and I think Susie's covered, just mention all these things, reference to previous investigations, correlate with any clinical history, mention whether they're solitary or multiple, and be consistent with site as well and levels, unilateral, bilateral, and obviously known relevant clinical history as well. So thanks for listening. Any questions at all?
As an incidental, so I don't do FNA.
So yeah, often me and Michael get sonographers do come to us with queries, and the good thing with our PAC system is we have a chat function where they can send a link to the lymph node. What I would say though, that is dynamic assessment is the best way. So I would grab someone to just have a scan as well if you can, and if not, if you're not sure, I would just recall it for a head and neck list because yeah, they can be very difficult.
What kind of urgency?
A 2 week wait urgency for anything really, because I think you can just never be 100%. Yeah. Yeah.
2 questions, is that right? So the first is, if you're doing an FNA for a cystic lesion, I was told that you try and get some of the cyst contents and then you try and get some of the wall.
Yes, right? Yeah, that's correct. Perfect. Yeah, so that's really important as well, because of any cystic contents may just come back inadequate or with inflammatory debris and stuff like that. But targeting the wall is a key thing as well. So that's one of the key things that we do when we're differentiating between branchial cleft cysts and SCC MET. We always target the wall as part of these samples.
And then my second question was, do you always go for FNA first, or would there be any cases where you do a core first? How do you decide between the two?
So if I saw something that looked like obviously lymphoma, I think that's the only thing that's recommended, that you get a core biopsy before FNA, histological diagnosis. If the patient had no comorbidities, wasn't on any blood thinners, and was clinically well, I would do a core. And obviously I would consent them, get their consent and things like that. And if they were happy to go ahead with that, I would go ahead and do it. But it depends on a lot of factors. But I think for lymphoma, for all the immunophenotyping and all the markers that they need, histological diagnosis is key. No problem.
And you said that you had that reactive node, then was later, I can't remember what the eventual pathology was, but is there sort of is there within radiology circles sort of a figure that a number of benign looking nodes turn out to be something suspicious, like there is in thyroid, like with U2s?
I'd say, yeah, I'm showing the worst cases. The majority of these are actually benign, but it's better to be safe than sorry. I'm probably more of a cautious radiologist than, so I'd say that probably like something like 80%, I'm just throwing a number out there, the majority of these are benign, but it's always best to be safe. And if the clinical history is worrying, and it depends on your level of suspicion and about how atypical it is it on the benign spectrum of atypical, is it malignant? And for the examples that I've shown, I actually thought these were malignant looking, that I didn't think these were benign. That was just to show that FNA may not give always the right example, and you should go with your morphological assessment and clinical history. So, but yeah, the majority of these do turn out to be benign.
I mean, I'd always caveat discharging somebody with it, if it grows,
exactly.
Come back, but
absolutely.
yeah.
Thank you.